So I'm going to talk maybe a little bit about world travel and travel here in the US. I'm going to talk about what I do in two roles. One is at my company, which is called Gobi Group, based here in California, and the other is what I do in my teaching role here at the School of Public Health at Cal. In both of those roles, what I'm doing is bringing sensibility around human-centered design, community-based design to problems in the social impact space. So, when I came here, a little bit of best lab history, when I came to Cal in 2003 to work with Alice, I was working on, I think, stuff that could display charts up here. I was in the AI space, was working on multi-agent systems, and had the opportunity to do some work in the design space in South India. Sort of came to this realization that this was the sort of work I wanted to do. I wanted to take experience I had previously in human-centered design in consumer electronics with Nokia and apply that to important societal problems, which some of which continue to be technical and some of them maybe not quite as much. And so I do that in, like I said, in a couple of different roles, the teaching role as well as the work role. Gobi is a company that I started with a couple of colleagues, like-minded colleagues who also were working in this space right after finishing when I graduated some years ago, 2008. And when I talk about human-centered design, we talk about human-centered design, design thinking, systematic innovation, in some cases community-based participatory research, quality improvement, total quality management. To me, there are distinctions between all of these design approaches, but really at the core, the philosophy and the sensibility is the same. That is, we're trying to understand problems from the perspectives of our customers. We're trying to understand problems in context. We're trying to leverage small-scale experiments to try out new ideas, and we're trying to just make things better. So I want to take you through a couple cases, a couple questions. Often this design process is really about landing on the right question through this, this direct research, this direct engagement with your customers. And so this is a question that one of my student teams, make sure I got the order right, yeah, one of my student teams came to, and this was a team last spring. So 3 people in this class. This class that I teach is now called Eat, Think, Design. It's modeled on Alice's new product development course. It's simply in the context of public health. So we bring together people that work in public health. They're not necessarily public health students. We get students from the business school, from engineering, from journalism, from the information school, and so on. They come together and they learn about the design process, and they apply that process to real projects in the food system space. And so this team, I'll show you a picture of one of them. Ben, Michelle, and Sarah all came from different corners of campus and different professional experience. One is a public health nutritionist. One is a city planner. Ben is a chef who became a primary care physician and came in for what's effectively an executive master's of public health degree. They came together and they wanted to look at providing, I'd say, market-based access to convenient, healthy, tasty food. So this is, especially those of you that live in like one of the big metro areas anywhere, not just in the US, may be familiar with meal kits. So a meal kit, I think the biggest player right now in the US is a company called Blue Apron. Heard of Blue Apron? Okay, so what Blue Apron is, it's a delivery service. They will give you a box of meals with all the ingredients in it. And the ingredients, like down to, if you need 12 flecks of red pepper, they'll give you a little baggie with like 12 flecks of red pepper in it. So you'll get 3 different recipes, and that'll be enough for a certain number of meals. You don't need to go shopping. You don't need to make any decisions around what you're gonna make. All the instructions are there for you. It's shipped to your door. It's the ultimate inconvenience. The food is really tasty. It is healthy. So they're sort of marrying these concepts of healthy but actual desirable food. The only problem is that it's not really that accessible to the masses. A box, I believe right now, industry standard is about $60 delivered to your door. There's also a values challenge because a lot of the people that are really into this idea of eating like healthy, good food aren't so keen on all the packaging that comes with a massive box with refrigerated meat, for example, in it. And so this team wanted to figure out how they could take that concept of meal kit and essentially convert it into something that would be more accessible for what they're calling the 80%. So in public health, often we talk about reaching like the last mile, or maybe the unreachable, the sort of 20% that's lowest income in a particular population. What they see is that with Blue Apron and these other competitors, there's actually a huge market opportunity sort of in the middle of 60% that they want to reach. And what they're doing right now is, so they got, I mean, I shouldn't say it's on tape, they got written up as a part of this very long, long piece about meal kits in Fast Company, which was actually fantastic because that gave them extra momentum around partnerships. It's still a very early stage venture called Cooking Simplified. This is Ben, he's the chef physician. And they have a couple of innovations which might not sound so fancy and amazing, but it's a way for them to bring down the cost while maintaining quality. And all of this is borne out through that engagement with customers, through this idea of small tests. They've already run, they're now on their third iteration of simply creating boxes, finding customers, selling them boxes, and getting feedback from those customers. And that's, for a lot of our students, that's a very different mentality than they're used to. They're used to going through lots of cycles of planning and analysis, coming up with a business plan, trying to pitch the idea to get funding without actually going to their customers, creating the product, seeing how good it tastes, modeling the costs. One of their innovations is pre-cutting vegetables, which can actually bring down costs in a couple of different ways. And one of the ways that it does it is you can get access to still high quality produce, but produce that isn't pretty. So if your produce, this is not just a US thing, but if your produce doesn't meet specific standards, it cannot be sold as whole fruit. So there's a whole movement in France, in the UK, and now in the US to sell this ugly fruit. Here what they're doing is getting access to lower priced fruit that still has that same intrinsic quality and chopping it up so that the customer doesn't know. So we'll see what ends up with it. It's, like I said, it's still very early stage for them, but I'm very excited that as a change, 3 minutes, as a change to what we've done previously in the class, which is always work with clients, so we actually have new ventures that are starting to emerge. So one other case I'll tell you about, and this is, I think, quite different, and this is part of the reason I wanted to share this, is while we're working in social impact, we're really trying to apply this, this design process to like varied challenges that are just improving society at large. So another one is ensuring that patient data is accessible and actionable in paper-based health facilities, particularly in fragile states. For the last 6 months, our team at Gobi has been working with the US government and other partners in Liberia, Guinea, and Sierra Leone in the wake, or sort of the current Ebola epidemic. The Ebola epidemic, which really started to peak late last year, was very unprecedented. Ebola had never really been in this part of West Africa. I talked to a colleague who said it would be like, you know, Ebola just showing up in Colorado out of nowhere if this Ebola epidemic hadn't happened. It had been further south in Eastern Africa, but it's a huge continent, and for it to actually show up in a place like Guinea was wholly unprecedented. And you know, I just checked the stats this morning. I think we're now at nearly 28,000 cases and nearly 12,000 deaths. And it was a big thing here for a short while. It was in the media, and then it went away. And it's sort of come back the last week because there's a potential case, if you follow the news, in Alabama, and some firefighters have been quarantined. There was somebody who was traveling back and forth to West Africa and possibly has contracted Ebola. We're not in the clear yet. The epidemic is ongoing. Our work is focused on looking at the information complexity and figuring out ways that we can do things better next time, to actually build systems that can be responsive and that can be stable in epidemics when we don't know what that next epidemic is. We can't over-engineer our information systems for Ebola, for example, which has a lot of particularities around it, because the next one probably won't be Ebola, and it might not be in Liberia. What you see here is a board from what's called the War Room in Monrovia in Liberia. This was actually used, this is how they were tracking information at the national level. So they didn't have the system set up yet, but they had a war room where all the key partners would come together, and this is how they were tracking cases and how they were tracking deaths, and we've obscured some of the patient information. That's why it's blurred out. This is one of the solutions we've landed on. And we just published an article about this in Vice to sort of generate some interest in this concept. The original question that I posed was around actionable data and accessible patient data in paper-based health facilities. Our mode in global health has been to push for wholly digital electronic health record systems, and frankly, that approach has failed. So what we're doing now is partnering with a local company called Captricity, which has developed a technology that lets you fill out, this is an actual form from Liberia. This is a redesigned form. What they do is they encourage good form design. They use some moderate artificial intelligence to scan, disaggregate the information. They have a human element to the technology as well, something like Mechanical Turk on the back end that lets you essentially take this form filled out by somebody who would have filled out this form and instantly enough digitize that information. So what we're doing is developing a system called Responsive Records, which is a hybrid electronic health record system that allows you to still stick with that culture of filling out paper forms, which is not unique to West Africa or unique to countries other than the US, and more or less on the timescales that matter for these health systems, create digitized information that's then actionable not only at a national planning level, but also at a clinic or facility level. And what I want to bring us back to is the way that we got to this was not just sort of thinking in a box. It was about applying that design approach and having our team in the field and actually spending considerable time doing facility assessments, talking to the people that fill out these forms, tracking what happened. The sort of innovation at the end, whether it's this or whether it's Cooking Simplified, really results from a diligent way of applying that process. So a couple of examples, and I'd love to take questions or chat with folks on the side about what we're doing. Thank you.
Thank you, Jaspal.